Hi everyone, I am Dr. P. Cheramannan, Principal, Sri Sairamhomoeopathy Medical College Research Center, Chennai. Actually today what we are seeing means that we just enter into the virtual. You already know about that one. Because in COVID, everything is changed from classroom to virtual. So today we are also doing the activity. Actually this activity is done for the students and also guided by our teaching staff. Okay, that is, we have the pathology and microbiology department. You already know about that one. It is also that BHMS is on par with the MBBS. So we also having the pathology and microbiology. The portions are same. You already know about that one. Okay, so now we just you enjoy that one. Actually, you are not study about that one. You just enjoy about that one, because you already know that when the pathology, when you take that pathology, it is divided into three one. Okay, one is the general pathology, and also it will include microbiology and parasitology. Okay, so the students are nicely doing that one. Actually, in this connection, first of all, I am very much thankful to Dr. Lalita Pankajam ma'am. She is a professor in the Department of Pathology, and also Dr. Bhuvanesh. He is also a reader in the Department of Pathology, and also very important to my dear students, because by their guidance they are only doing that one. So it is only somewhat different. It is not the microscopic or macroscopic features. They just do in the different one. Okay. So in pathology they just explain the household things, and in microbiology they just explain the antique jewelry, and also in parasitology they just show the life cycle of parasites in the SARI excretion. It is a somewhat different. Okay, you already see, because we already posted a similar type of activity in our Department of Pathology. So you are also enjoying, and give your feedback in the comment box. Thank you very much.
Hello everyone, I am Dr. Lalita Pankajam, Professor, HOD, Department of Pathology and Microbiology in Sairamhomoeopathy Medical College, Chennai. In our department, 3 years back, we had to upload a video of anemia part, followed by last year we have to upload and syllabus garden in our official channel. This year I created a new different kind of ideas, and I give a topic of Botique. I create the idea how to students study easily pathology, models and microbiology, microorganisms and parasitology life cycle. So it is a very interesting way they are studying, and easily understandable mode of, we have created a new concept of this. So we and my staff and second year students, we are created and presented here the boutique shop. It is take about 3.5 months. So it is a household things and sarees and antique jewelry, different mode of the presentation here. I thank my management, chairman sir, CEO sir and CBO sir. A lot of support in this one. And special thanks to my principal sir, backbone of this work. Thank you. And also I deliver my thanks to my department staff and students for this work grand success. Thank you.
Dr. Bhuvanesh, Associate Professor, Sri Sairamhomoeopathy Medical College, Chennai. In our department, under the guidance of HOD, Department of Pathology and Microbiology, we have discussed to bring out the new concept or emerging action of the students with the HOD, and this frame or this given a pathway to enumerate the student with the potential. And these are the works done by the students the time period of 3.5 months. And students are given the full effort, support and creativity to bring out the complete effort of the work. And you will be watching the complete work of the students, which are being made with the help of HOD and the principal. And I think, and thanks for your support given in previous videos of anemia part and syllabus burden, and thanks for your support. And I I think you will like this video and the work done by the student or the effort created by the student is wonderful, and you just keep on watching this video, like this video, share this video, and I take this opportunity to thank management, principal sir and HOD madam who has constantly given their support and supporting us and students to make this effort successful. Thank you.
Hi viewers, we are the second year students of Sairamhomoeopathy Medical College, taking an immense pleasure to show the world how we enjoy learning pathology, parasitology and microbiology. First of all, we are very much thankful to our college management, CEO, CBO and principal for giving this wonderful opportunity to showcase our talents. Actually, we had a project for our curriculum. Our head of the department, Dr. Lalita Pangacham ma'am, had a wonderful idea to fulfill their task. She gave us an idea to put the Troizean's Botique, in which we have presented 15 pathological conditions as household products, 12 fancy sarees representing parasitology, and 18 antique jewelries representing the morphology of various bacteria. This project is a classic example of a teamwork. There are 35 students in which we have been divided as financing, purchasing, organizing and executive teams. This successful project is nothing without our backbone. Our pathology professor, Dr. Lalita Pangacham ma'am, and our microbiology and parasitology professor, Dr. Bhuvanesh sir. This video would be a great read to your eyes and brain. Let's get into the video.
Hello everybody, we are Team Pathology, a team of 16 students under the guidance of Dr. Lalita Pangacham, Head of Pathology and Microbiology Department, and Dr. Bhuvanesh, Associate Professor, have creatively presented 15 pathological conditions in the form of household appliances. Initially, when we were assigned this activity, we had no clue of how we were going to present 15 pathological conditions in the form of household products. But under the guidance of Dr. Lalita ma'am and Dr. Bhuvanesh sir, we are successfully able to present our models to you all. Our professor stood behind each one of us and provided a strong support and interesting ideas during the making of our models. After repeated sessions of discussion and a lot of behind the screen work, we, Team Pathology, present to you all an interesting few minutes of 15 pathological conditions. The topic that I've taken is arteriosclerosis. I've represented arteriosclerosis in the form of doormat. Arteriosclerosis generally includes conditions in which there is thickening and hardening of the vessel wall along with obliteration of the lumina. Arteriosclerosis is of three types: hyaline arteriosclerosis, hypoplastic arteriosclerosis and necrotizing arteriolitis. The first form is hyaline arteriosclerosis. Morphological pattern that is visible in hyaline arteriosclerosis is thickening and hardening of the vessel wall along with obliteration of the lumina. The microscopic features that are visible in hyaline arteriosclerosis is presence of structureless eosinophilic hyaline material. The second type of arteriosclerosis is hypoplastic arteriosclerosis. In hypoplastic arteriosclerosis, there is thickening of the tunica intima of the blood vessel wall. The tunica intima shows three types of thickening. The first one is onion skin lesion, second type is fibrotic intimal thickening, and the third type is mucinous intimal thickening. The third type of arteriosclerosis is necrotizing arteriolitis. In necrotizing arteriolitis, there is infiltration with inflammatory cells along with presence of edema of hemorrhage around the affected blood vessels. This brings arteriosclerosis to an end. I now call upon Ovia to explain about her presentation.
Hi, I'm Ovia. My model is thromboangiitis obliterans resembling a pizza tray. Thromboangiitis obliterans are Burgers disease. Is a specific disease entity affecting the small and medium-sized arteries and veins of extremities, characterized by acute and chronic occlusive inflammatory involvement. It is most commonly seen in men under the age group of 35 years who are heavy cigarette smokers. Grossly, the lesions are segmented, affecting the small and medium-sized arteries, including adjacent veins and nerves. Microscopically, in early stages, there is infiltration of polymorph in all the layers of vessels. In presence of thrombosis is also seen. In advanced stages, the infiltrate is mononuclear and the epithelial cell granuloma is also present. In chronic cases, fibrosis is also seen. Now, my friend Sweetlyn will present our model.
Thank you, Ovia. Hi, I'm Sweetlyn. I have made a model of aneurysm in the form of toy box. Aneurysm is defined as permanent abnormal dilatation of blood vessels occurring due to congenital or acquired weakening or destruction of blood vessel. It occurs commonly in large elastic arteries, especially aorta and its major branches. Aneurysm can be classified on the basis of composition of the wall, shape and pathogenetic mechanism. Atherosclerotic aneurysm of the abdominal aorta is most frequently infrarenal above the bifurcation of the aorta but may sometimes extend into the common iliac arteries. It is fusiform in shape and the lumen may contain neurothrombus. Syphilitic aneurysm is most commonly occur in ascending part and arch of aorta. It is circular in shape, less often it is fusiform or cylindrical in shape. Dissecting aneurysm differs from atherosclerotic and syphilitic aneurysm in having no significant dilatation. It begins from the arch of aorta and extends proximally into the aortic wall ring and distally into the abdominal aorta. Thank you. Next, I call upon Kavya Swarupa to explain about her model.
Thank you, Sweetlyn. Hi everyone, this is Kavya Swarupa. I have made a model on rheumatic endocarditis in the form of pen stand. Rheumatic endocarditis. It is an inflammation of the inner layer of the heart, mainly the chambers and the walls. The endocardial lesions of rheumatic fever involves two conditions. The first one is the valvular endocarditis and the neural endocarditis. Coming to valvular endocarditis, in this the valves become thickened, loses its translucency and the vegetation appears as small, multiple and global. They do not get detached to form emboli, whereas in infective endocarditis they detached and form emboli. In this, the mitral valve is affected most, which is present in between the left atrium and the left ventricle. The mitral valve and pulmonary valve shows infrequent and slight movement. Coming to chronic stage, in this there will be a permanent deformity of the valves, especially the mitral valve and the aortic valve. That is, about 37% of cases the mitral valve is affected and 27% of cases the mitral valve and aortic valves are affected and 22% of cases the mitral valve, aortic valve and pulmonary valves are affected and about 11% of cases the mitral valve and tricuspid valves are affected and about 2% of cases the aortic valves alone are affected and about less than 1% of cases all the four valves are affected. In this, the healed chronic mitral valve, it is characterized as a fish mouth or buttonhole stenosis. Coming to the second part, that is rheumatic mural endocarditis. Here we can see the patch known as Maculum's patch. The Maculum's patch is present in between the posterior wall of the left atrium, just above the posterior leaflet of the mitral wall. It is a map-like structure which is roughened, thickened and wrinkled part of the endocardium. Thank you.
Hi, I am Nityashri. Now, I am going to explain about valvular deformity. Valvular deformities are of two types. One is stenosis and another one is insufficiency. Here is my model, normal mitral valve, mitral stenosis and mitral insufficiency. Now, we are going to see about mitral stenosis. The appearance of mitral stenosis depends upon the basis of its involvement. In less extent cases, the base will be mobile and the valve leaflets are thickened and puckered, which looks like a purse string puckering. In most advanced cases, the valvelets are rigid, mobile, immobile and fixed like diaphragm, which are called as the slit-like or fish mouth oval orifice. Now we are going to see about mitral insufficiency. It occurs in cases who are affected with rheumatic heart diseases. It depends upon two factors, which are myxomatous degeneration and the another one is non-inflammatory calcification. In myxomatous degeneration, one or both the valve leaflets gets into the left atrium during systole. Non-inflammatory calcification. It occurs in aged persons. It represents the aged persons, and there will be a irregular stony hard bead-like thickening present in the valve leaflets. Thank you. Now I call upon Akshaya ji to explain about aortic stenosis.
Hi everyone, I am Akshaya. I have done 3 models, namely normal aortic valve, aortic stenosis and aortic insufficiency, which represents the snack split. Now I am going to explain a few points about aortic stenosis. In aortic stenosis, the aortic cusp became thickened and forming characteristic fibrous thickening and calcific nodularities of the closing edges. In rheumatic aortic stenosis, the commissures are thickened and fused. Where in non-rheumatic aortic stenosis, the commissures are not fused as well. The major effects are obstruction to the outflow of blood. The precordal symptoms of aortic stenosis are exertional dyspnea, angina pectoris and syndrome. So my next model is about aortic insufficiency. In aortic insufficiency, the valve became thickened, deformed and shortened. So there is generally a distension and distortion of the rings. The major causes of aortic insufficiencies are chronic rheumatic heart disease, traumatic rupture of the valve and syphilitic endocarditis. So as a result of regurgitant aortic orifice, there will be an increased left ventricular endodiastolic valve. This leads to hypertrophy and dilatation of the left ventricle. Thank you. Now my friend Bala Murugeshwari will take over her part.
Thank you, Akshaya. Hi, I am Bala Murugeshwari. My model is silicosis lung, which resembles flower vase. Now we are going to see few words about silicosis lung. The silicosis lung is also called as a knife grinder's lung. The silicosis lung is caused by the prolonged inhalation of the silicon dioxide, which is commonly called silica. The silica constitutes about 3/4 of the earth crust. Morphological features. Grassly, the chronic silicotic lung is studded with odd fibrotic nodules, which is of 1 to 5 mm in diameter, and it is scattered throughout the lungs. This nodular lesions consists of coal dust depositions which undergo calcification. The pleura is grassly, thickened and adherent to the chest wall. These nodular lesions may also undergo cavitations. Histological features. The following are observed. The silicotic nodules are present in the adjacent alveolar respiratory bronchioles and in the regional lymph nodes. This silicotic nodules contains an ionized material with scanty cellularity and some amount of dust particles. The intervening lung parenchyma shows hyperinflation or emphysema. Thank you. Now I call upon my friend Erin Vinci Noel to explain about her model.
Hello, I'm Erin Vinci Noel and I'm here to explain about my model mesothelioma. I have made this model in the form of teapot. Mesothelioma is an uncommon tumor arising from the mesothelial lining of the serous cavities, most commonly affecting the pleural cavity, rarely the pericardial cavity and the peritoneal cavity. Let us see about its types. The first type is benign or the solitary type of mesothelioma. Grossly, they are solitary, circumscribed and small firm mass which is less than 3 cm in diameter. The cut surface shows dense fibrous tissue. Microscopically, collagen and reticulin with fibroblasts are found. The second type is malignant or the diffuse type of mesothelioma. Grossly, they are diffuse, thick white fleshy coat which is covered all over the parietal and visceral surfaces. Microscopically, 3 types of patterns are observed. The first pattern is the epithelioid pattern, which resembles to that of an adenocarcinoma with tubular and tubulopapillary structures. The tumor cells are well differentiated as columnar, epithelial and the flattened cells. The second pattern is the saccharomatite pattern, which resembles to that of a fibrosarcoma. The tumor cells are arranged in the form of storiform pattern. The third pattern is the mixed pattern, which consists of both the epithelioid pattern and the saccharomatite pattern. There are usually slit-like pores which is lined by the neoplastic mesothelial cells. Here we should note asbestos bodies are found in the patients who are affected with the malignant type of mesothelioma. Thank you. I now request my friend Divya Priya to explain about her model.
Thank you, Erin. Hi, I am Divya Priya. Here's my model. This is an ulcerative colitis, which means pregnancy below. I am here to explain few words about Crohn's disease and ulcerative colitis. Crohn's disease. Crohn's disease is a chronic idiopathic form of inflammatory bowel disease, mainly present in terminal ileum. Ulcerative colitis. Ulcerative colitis is mainly present in the rectum, sigmoid colon and descending colon. Both of these are present in the bowel, but as systemic involvement of skin lesions, hepatic involvement. Morphological features of Crohn's disease. Gross. The appearance of colon may be various according to the disease. Mucosa shows serpiginous ulcer in microscopy. Patchy ulceration may be present. In chronic cases, fibrosis occur. In chronic cases, fibrosis may occur in certain diseases.
morphologic disease of ulcerative colitis. Gross. Mucosa shows linear superficial, intact mucosa shows pseudopolyp. Histology. Goblet cells seen in acute cases, marked congestion, hemorrhage and dilatation may be seen. Focal accumulation of neutrophils seen. Okay, thank you. Now I call upon my friend Subhashri to explain about her model.
Thank you, Divyapriya. Hi, I am Subhashri. I am here to explain about my model chronic hepatitis, which indicates baby cradle. Chronic hepatitis is continuous relapsing of hepatic diseases for more than 6 months, along with the biochemical, serological and histopathological evidence with inflammation and necrosis. Morphological feature. The pathological features are more common in HPV and HBC. Here are some following lesions. Piecemeal necrosis is also called as interfront hepatocytes. It is defined as a periportal destruction of hepatocytes in the limiting membrane. Next, we see upon the portal tract lesion. In portal tract lesion, all the chronic hepatitis we can see have different varieties, degrees of lesions, in which inflammation infiltrate cells of hepatic tissues, plasma cells and macrophages. Interlobular lesion. Interlobular lesion, generally we can see about the architectures of the lobules are different. So, the scattered of acidophilic bodies on the lobules and Cooper cells hyperplasia. In most severe cases, we can see bridging necrosis, and in the cases of hepatic C, we can see a very common fatty tissues. And in hepatic B, it is very severe. Bridging necrosis is most common factors are irreversible damages, in which we can see the portal tract to portal tract and central vein to central vein. Thank you. Now I call upon my friend Inia to explain about our model.
Thank you, Subhashri. Hi, I am Inia, and here is my model alcoholic liver cirrhosis, which resembles the night lamp, and I am here to explain few words about the alcoholic liver cirrhosis. In other terms, it is called as diffuse cirrhosis and nutritional cirrhosis, and it occurs in 60 to 70% of cases. First, we move on to the gross features. In this, the liver is large, fatty, and it weighs about 2 kg, and over the span of years, the liver becomes shrinks and it weighs about 1 kg. And the surface of the liver is studded with the fibrous nodules, and it appears yellow in color. Then we move on to the microscopic features. In this, nodular formation is present. It has the central veins, which is rare to find, and it is replaced by the nodular formation. Then the fibrous septa, which divides the hepatic parenchyma into septa, and it is dense. Then the hepatic parenchyma, which undergoes the slow proliferation. Then is necrosis, inflammation, and finally the bile duct proliferation. Thank you. Now I call upon my friend Haripriya to explain about her model.
Thank you, Nia. Myself, Haripriya. I made a model on chronic cholecystitis, which resembles the pouch bag. Chronic cholecystitis. The gallbladder wall is generally contracted, may be normal or enlarged. The wall of the gallbladder is thickened, calcified or due to fibrosis. Histologically, thickened or congested mucosa, but occasionally the mucosa may be totally destroyed. Penetration of the wall of the gallbladder is due to formation of the Rokitansky-Ashkoff sinuses. The variable degrees of the chronic inflammatory responses like macrophages, lymphocytes, plasma cells are present in the subserosal layer. The variable degrees of the fibrosis are present in the subserosal and subepithelial layer. Few morphological features like cholecystitis glandularis, where the mucosa folds fuse together due to inflammation for the formation of crisps of epithelium. Posterior gallbladder is where the pattern of the wall of the gallbladder is calcified. Acute on chronic cholecystitis. Acute cholecystitis, the morphological changes are superimposed on chronic cholecystitis. Thank you. And now I call upon my friend Padma Priya to explain her model.
Thank you, Haripriya. Hi everyone, I am Padma Priya and I have made a model of chronic pyelonephritis resembling a leaf fan. Chronic pyelonephritis is a chronic tubular interstitial disease resulting from a repeated attack of inflammation and scarring. Depending upon the etiology and pathogenesis, there are 2 types, reflex nephropathy and obstructive pyelonephritis. Reflex nephropathy is nothing but a backflow of urine back into the ureter, whereas obstructive pyelonephritis is due to there will be an obstruction in the ureter, so the urine cannot be passed out. Grossly, the kidneys are small and contracted, unequal reduction, which distinguishes it from other forms of the contracted kidney. The surface of the kidneys are irregularly scarred, so that now the capsule is very difficult to take off since it is adherent to the scar. The scars are variable in size and it is completely different from other forms of the kidney. Microscopically, the predominant changes are seen in interstitium, tubules, blood vessels, glomeruli, etc. In interstitium, there is a chronic inflammatory reaction involving macrophages, plasma cells and others. The accumulation of foamy macrophages stages along with other inflammatory cells are known as xanthogranulomatous pyelonephritis. In tubules, there will be an atrophy, and in glomerulus, that after capillaries are in contact with the scars, there will be periglomerular along with the hyalinization of the glomeruli. Thank you. Now I call upon my friend Jayadashni to explain her model.
Thank you, Padmapriya. Hi, I'm Jayadashni. I made a model of renal cell carcinoma in the form of mud. Renal cell carcinoma is an adenocarcinoma arising from the proximal renal tubular epithelium. Based on cytogenetics of sporadic and familial tumors, it is divided into clear cell type, papillary type, and lymphoid type. Renal cell carcinoma commonly arises from upper folds of the kidneys, which is usually solitary and unilateral. The tumor is large, golden yellow, and circumcised. The cut section of the tumor shows large areas of ischemic necrosis, cystic change, and foci of hemorrhages. Clear cell type contains of 75%, and the clear cytoplasm is due to the removal of glycogen and lipid. Papillary cell type comprises of 15%, and it has papillary pattern all over the tumor. It has small round nuclei. Clinical symptoms. Renal cell carcinoma is a slow-growing tumor, and the classical clinical evidence is gross hematuria, flank pain, and palpable abdominal mass. The other symptoms are fatigability, weight loss, cachexia. It also includes polycythemia, hypercalcemia, hypertension, and effects of feminization and masculinization and Cushing syndrome. Thank you. Now I call upon Sharmila to talk about her model.
Thank you, Jayadashni. Hello, myself Sharmila. I have made hydatiform mole model, the form of fruit cake model, for the easy demonstration of the students. What is hydatiform mole? The name hydatiform, which is the drop of water, and mole is the shapeless mass. It is defined as the abnormal placenta, which is characterized by two features. One is the trophoblastic proliferation, and other is the edematous hydropic changes of the chorionic villi. And then the morphological features, the pathological finding, which is invasive and non-invasive type. Non-invasive type is of two types, which is complete and partial mole. Complete mole is of gross leaf, which is the size of the uterus will be very much enlarged and is filled with the grape-like vesicle, which is of 3 mm in diameter, and these each vesicles are filled with water-like fluid. And microscopically, the vascularization is very much decreased, and the trophoblastic proliferation of cytotrophoblast and syncytial trophoblast are present. And then the partial mole, in which the size of the uterus is very much decreased than the expected, and then the cystic villi occurs, and the part of the placenta will appear normal. And microscopically, the cystic villi shows the edematous changes. And then the invasive type. In invasive type of mole, the edematous changes occurs, and the tissue will invade the wall of the uterus, and microscopically the beta HCG level will be elevated. Thank you, and now I call upon the microbiology team for continuing the session.
models, and antique jewelry and transform them into a boutique. To begin with, first, let's see about the shapes of bacteria. Depending upon the size and the shape, bacteria can be classified into various types. This feature of bacteria is known as pleomorphism. Pleomorphism is often a result of defective cell wall synthesis. I have created a step chain in order to explain the same. In the first row, we have cocci, derived from the word coccus, meaning berry. Species like Staphylococcus and Streptococcus belong to this layer. In the second layer, we have bacilli, which means rod-shaped bacteria. Species like E. coli and Proteus belong to this layer.
In the following layer, we have Diplococci gram-positive. And in the next layer, we have Vibrio, meaning comma-shaped bacteria. Species like Vibrio cholerae belong to this layer. And in the next layer, we have Diplococci gram-negative. And in the final layer, we have Spirals. Species like Spirillus mealis belong to this layer. Thank you. Up next, I call upon Abhirami.
Thank you, Safala. I am Abhirami. Now I am going to explain about Staphylococcus, which are made in the form of chain. Staphylococcus are gram-positive spherical shaped cocci measuring in size about 0.5 to 1.5 mm. They are non-motile, non-sporing and capsulated organism occurring in golden, yellow and opaque colonies. The pathogenesis of Staphylococcus, they adhere to damaged skin mucosa in which they evade the defense mechanism of host, colonize and cause tissue damage. Staphylococcus also cause toxic shock syndrome characterized by high fever, hypertension, vomiting, diarrhea and scarlet uniform rashes. Staphylococcus are diagnosed through hematological and bacteriological investigations. Thank you. Now I call upon Lavanya.
Thank you, Abhirami. Hello everyone, I am Lavanya. I have presented the Streptococcus in the form of an earring. Streptococcus, these are gram-positive bacteria and are arranged as chains. These are non-motile, non-sporing, does not produce any pigmentation in colonies. Pathogenesis. Transmission is mainly through the food, fomite and droplets. It enters through the skin and throat. It produces infections to the cutaneous and respiratory, mainly in children. The lab diagnosis. It is sputum examination and speculum examination. Clinical features, it produces impetigo, throat infection, acute rheumatic fever, scarlet fever and toxic shock syndrome. Up next, I invite Salman to continue this session.
Thank you, Lavanya. I am Salman. I am here to explain about the pneumococcus, which is made in the form of Homoeopathy. It is a gram-positive, non-solid shaped diplococci, which is small and has a diameter of 1 mm. It is an elongated diplococci with one end broad or rounded. Here we come to pathogenesis. The colonies in the human nasopharynx cause infections in the otitis middle ear, paralyzes sinus and lower respiratory tract, which cause otitis media and pneumonia, where the normal defenses are comprised by the viral infection and anesthesia. The lobar infections of the pneumococcus are bronchopneumonia, lobar pneumonia, pneumococcal bacteremia and pharyngitis. The non-invasive infections are otitis media and sinusitis. Here we come to laboratories. They are biosulfate test, optosensory test and antigen detection using lattice aggregation test. I have also made Neisseria meningococcus in the form of ring. It is a gram-negative, lens-shaped diplococci with polymer aerobic, non-motile, non-sporing and oxidate positive. It forms circular colonies. Here we come to pathogenesis. Human are the only natural host for the meningococci. The most common source of infection occurs in the nasopharynx. The spread of infection occurs through hematogenous route, direct spread along the olfactory nerve and the conjunctiva. Most mode of transmission occurs through the droplet inhalation. Here we come to laboratories. They are nasopharyngeal swab culture and a series of examination. Thank you. Next I invite Mukesh to continue the session.
Thank you, Salman. I am Mukesh. I am here to explain about the Neisseria gonorrhea made in the form of ring. Neisseria gonorrhea is a gram-negative, kidney-shaped diplococcus. It is non-capsulated. It causes gonorrhea, cervicitis, conjunctivitis and urethritis. Its pathogenesis and clinical features are gonorrhea is caused by the Neisseria gonorrhea. In male it causes acute urethritis. In female it causes vulvovaginitis, mucopurulent cervicitis. Its lab diagnoses are in male it is a urethral swab and in female it is a cervical swab and a rapid carbohydrate utilization test and finally gonorrhea are the catalase and oxidase positive. Thank you. Next I invite Afrika to continue this session.
Thank you, Mukesh. Hi, I am Afrida. I have made Corynebacterium diphtheria in the form of a choker nucleus. Corynebacterium diphtheria is a gram-positive bacteria, non-motile, non-sporing, non-acid phosphate stains. They are occurring pairs, parasites and in groups. The three important antigenic structures are Gravis strains, intermediates and mites. The pathogenesis starts with the help of diphtheria toxins. Diphtheria toxins has two fragments, fragment A and fragment B. Fragment A stops the polypeptide chain elongation in the presence of NAD, whereas fragment B helps in binding. The diphtheria toxin has the incubation period of about 3 to 4 days. The commonest site of infections are conjunctival, nasal, oral, cutaneous, genital, pharyngeal and laryngeal. For the laboratory diagnosis, in vitro tests such as ELISA, PCR, immunochromatography, ELIX gel precipitation test can be done. And I also made Clostridium perfringens in the form of an HUT. Clostridium perfringens are gram-positive bacteria. They have spores which are heat resistant. They are highly pleomorphic and motile with its peritrichic flagellae. They are found in the gut of the human and animal as a commensal floras. They have 4 major toxins and 8 minor toxins. The pathogenesis starts when the wound is get in contact with the contaminated soil by the bacterium. The interruption to the blood supply and the low oxygen levels supports the growth of the bacteria. Gas gangrene, food poisoning, necrotizing enteritis, gangrenous appendicitis are its clinical manifestations. Robinson cooked meat broth, litmus medium are used for the laboratory diagnosis. For the reduction of acid, clot and gas, litmus medium is used for the further diagnosis. Now I call upon Ms. Shalini to continue.
Thank you, Afrida. Hello everyone, I am Shalini. Now I am going to explain about the Proteus mirabilis. I have created in the form of earrings. Proteus mirabilis is a gram-negative, non-capsulated, pleomorphic and motile rods. Pathogenesis. It usually causes a urinary tract infection, and also swimming is thought to have to be contributed within the urethra and from the urethra to the bladder and also between the kidneys. The characteristic feature of this is the presence of fishy odor, and it also has a flagella so that it can easily swim. Then coming to a incubation period, it usually ranges between 1 to 3 days. Symptoms include fever, nausea, vomiting, diarrhea, abdominal pain and dehydration. At last, we come to a lab diagnosis. In case of lab diagnosis, 2 tests can be done. One is Wheel-Fields reaction, another one is ELISA. Wheel-Fields reaction is a cross reaction between the somatico-antigen and the flagella-rich antigen. And in case of ELISA, enzyme-linked immunosorbent assay. These 2 tests are usually carry over to detect the presence of Proteus mirabilis in the given culture. Now I call upon Safala to continue the session.
Thank you, Shalini. I am Safala and I am going to explain about Shigella with the help of these earrings. Shigella are gram-negative bacteria which are short, rod-shaped structures. These are usually measuring from 0.5 to 1.3 nanometers. These are non-motile, non-sporic and non-capsulated organisms. Usually these are found to have K antigen or O antigen. The pathogenesis of Shigella is as follows. As much as 10 or 100 organisms are enough to infect a human being. These cling on to the mucosa cells of the intestines and invade into the lamina propria and spread to the neighboring enterocytes. The clinical features are food poisoning, gas gangrene and gangrenous appendicitis. These can often be diagnosed using Robertson broth or Shigella broth. Thank you. Up next, I invite Lavanya.
Thank you, Safala. Hello everyone, I am Lavanya. I have presented the Salmonella typhi in the form of an bangle. Salmonella typhi, these are a gram-negative rod bacillus. These are motile with peritracheate flagellas. These are divided into typhoid and paratyphoid bacilli. Pathogenesis, it produces mild infection to severe infection and also sometimes it produces episodic diseases also. Clinical features, it produces enteric fever, gastroenteritis and septicemia. If incubation period is of 7 to 14 days, it produces complications like industrial perforation and hemorrhages. Lab diagnosis. The wider test. This is a test used for the measurement of the H and O agglutinin for typhoid and paratyphoid bacilli in the patient's serum. A positive result is good for diagnosis. Selenite F and tetrathionate is used as an enrichment media for the growth of this bacteria. Thank you. Up next, I invite Srinidhi to continue the session.
Thank you, Lavanya. Hello everyone. I am Srinidhi. I have presented brucella in the form of the bangle. It is small, non-motile and aerobic. It is a gram-negative coccobacilli. It also causes zoonotic infections. It is also known as Mediterranean fever, Malta fever and Andulan fever. The antigenic determinants are A and M. Brucella abortus is of A and Brucella militensis is of M. The Brucella militensis is most pathogenic and primarily it affects the reticuloendothelial system. The incubation period is of 10 to 30 days. Also it causes acute brucellosis and chronic brucellosis. The lab investigations are cultural characteristics, biochemical reactions and serological methods and standard agglutination tests like ELISA test. Thank you. Now I call upon my friend Abhirami to take over.
I am Abhirami. Now I am going to explain about Mycobacterium tuberculi, which I made in the form of aram. Mycobacterium are slender rods that do not stain readily due to the presence of mycolic acid in their cell wall. They are called acid-fast bacilli. They contain 3 groups: obligate parasites, saprophytes and opportunistic pathogens. The pathogenesis of Mycobacterium tuberculi: primary tuberculosis mainly affecting the lower lobe of the lung, and secondary or post-primary tuberculosis mainly affecting the upper lobe of the lung. The lesions are undergoing necrosis and tissue damage. The lesions are of two types, exudative and productive type. Mycobacterium tuberculi are diagnosed through tuberculin test, which is also known as Montauk's test, demonstrated by hypersensitivity to tubercular protein. Thank you. Now I call upon Srinidhi to explain.
Thank you, Abhirami. Hello everyone, I am Srinidhi. I have presented Treponema pallidum in the form of the pendant. Treponema pallidum is the causative agent for syphilis, and that was found in the inguinal lymph nodes of the humans. It is a very thin, delicated spirochetus that has 10 regular spirals. It is 10 micrometer long and actively motile that has 10 regular spirals, and the antigen structures are specific antigens and non-specific antigens. Certain groups and species belongs to the specific antigens, and the non-specific antigen is cardiolipin antigen. The pathogenesis is natural infection occurs only in human beings, but the rabbits gets infected through the intradermal inoculation. The same disease, syphilis, can also be produced experimentally in chimpanzees through typical lesions like primary lesions and secondary lesions. The lab diagnoses are dog-ground microscopy, standard test for syphilis, Treponema pallidum immobilization. Thank you. Up next, I call upon my friend Hussain to take over.
Thank you, Srinidhi. Hello, I am Today I am going to explain about water log process in the form of Kasi Malay. Homoeopathy is an infection is responsible for the infection in human beings. It is small ovoid gram-negative Lactobacillus which is uniform in size and shape. It is non-motile and non-sporing. It is capsulated but tends to lose the capsule on rapid cultivations. Pathogenesis incubation period is 1 to 2 weeks. There are three stages: lateral stage, proximal stage, and convulsing stage. Lab diagnosis: collection and transport of specimens, nasopharyngeal swab, nasal swab of plate method. Thank you. Now I invite Mukesh.
Thank you, Hussain. I am Mukesh. I am here to explain about the Vibrio cholerae. It is made up of in the ring. Vibrio cholerae are gram-negative bacteria. Vibrio cholerae is a causative agent of cholera. It is described as a fishing stream appearance. Its pathogenesis are that it is adhesion to the epithelial surface and produces the toxins. Its main toxins actions are the genetic action of enterotoxins and the mechanism of action of cholera toxins. Lab diagnosis: in male it is a rectal swab, in female it is a cervical swab, and rapid carbohydrate utilization test, and it is a catalase and oxidase positive. Thank you.
Thank you, Mukesh. I am Today I am going to explain about Pseudomonas aeruginosus in the form of earring. Pseudomonas aeruginosus is a cylinder-shaped gram-negative bacillus. It is about 1.5 to 3 into 0.5 μm in size. It is actively motile with a polar flagellum. Saprophytic clone is the hospital environment, equipment, and moist area. Pathogenesis: the bacteria has the ability to establish the pathogenesis if it is introduced into devascularized tissues through skin and mucous membrane. There are two types of infections: local infection and ordinary infection. The local infections are wound, eye infection, ear infection, and the ordinary infections are septicemia and ventilator associated pneumonia, and catheter associated UTI.
Thank you, Hussain. Now I am going to explain about the Bacillus anthrax. This I have created in the form of Otianum. Bacillus anthrax is a gram-positive, sporulated, capsulated, and non-motile rod. When coming to a pathogenesis, animals are usually getting infected by contact with the other animals. Ingestion of the spore is the most common one. The discharges are usually more, and also this Bacillus anthrax is usually found in the mouth, nose, and the rectum. Sporulation in the soil, which is surveyed for many years, becomes source of infection to other animals to infect. It is usually classified into three clinical types. One is cutaneous anthrax, another one is pulmonary anthrax, and last is intestinal anthrax. Pulmonary anthrax is usually transmitted by inhalation of the dust from the infected animals, and the intestinal anthrax is usually from undercooked meat. Then at last we come to a lab diagnosis. In case of lab diagnosis, in the cutaneous anthrax, first can be collected, and in the septicemia anthrax, blood test can be collected, and in industrial anthrax, suspected food or stool examination can be done, and in pulmonary anthrax, sputum can be collected to detect whether the bacillus anthrax is present or absent in the given culture. Now I call upon the parasitology team to carry over the session. Initially, when ma'am and sir engaged us in doing these activities, we had more confusions. They supported us in every way and made us enthusiastic in doing these amazing models. Here on screen, we have depicted 12 parasitology models and their life cycle. It will be detailed one by one by our team girls. First, I call upon Inya to explain the first parasitology model. Thank you.
Thank you, Mutthalakshmi. I am G. Inya. I am going to explain about the axel, Entamoeba histolytica, its life cycle, organism characteristics, clinical features and laboratory diagnosis. Entamoeba histolytica. Entamoeba histolytica mainly produces amoebiasis. It also causes intestinal and extraintestinal diseases. Entamoeba histolytica exist as trophocytes, pre-cyst and cyst. Trophocytes varies in ranges from 18 to 40 micrometer and they do not have definite shape. Life cycle. Entamoeba histolytica has simple life cycle. And the mesocysts are the infective forms. They infect human through contaminated food or water. Pathogenesis. Trophocytes invade tissues after penetrating the intestinal mucosa. This lack this ability. Trophocytes after invasion causes ulceration. Clinical features. Entamoeba histolytica causes intestinal and extraintestinal diseases. In intestinal diseases, there are non-invasive and invasive forms. In non-invasive forms, there appears to be asymptomatic and symptomatic diseases. In invasive forms, there are acute dysentery, fulminant colitis, chronic colitis, toxic megacolon, etc. Extraintestinal diseases. In extraintestinal diseases, there are brain abscess, lung abscess, and the most common manifestation of amoebiasis is amoebic liver abscess. Laboratory diagnosis. Stool examination is the most important to establish the amoebic dysentery. Presence of charcoal-laden crystals is also of diagnostic. Prevention. Therefore, proper disposal of sewage is important. Cleaning of raw fruits and vegetables before consumption is also important. Thank you. The next cycle will be explained by Priyadarshini.
Thank you, Inya. Hi, I am Priyadarshini. I am going to explain about Trypanosoma cruzi, its life cycle, organism characteristics, pathogenesis and lab diagnosis. General trypanosomas are Trypanosoma brucei gambians, Trypanosoma brucei rodensis and Trypanosoma cruzi. The first two species produce a sleeping sickness in Africa. Chagas disease is produced by Trypanosoma cruzi. It is more prevalent in Central and South America according to the first report released by WHO on neglected tropical disease in 2010. Organism characteristics. These produces two forms, amastigote and trypanomastigote. Amastigote lives in the nerve cells, cells of reticuloendothelial system and heart muscles. It is about 2 to 4 μm in diameter. It has a complex life cycle in which humans are the definitive host and redivivid bugs are the intermediate host. Pathogenesis. Chagoma is produced on the skin while the Romanas sign is produced as a result of unilateral swelling of the eyelids. It produces two forms, acute form and chronic form. Acute form is presented with fever and generalized non-pitting edema. Chronic form is presented with cardiological, viral and neural manifestations. Lab diagnosis: blood aspirated from chagoma and tissue specimen is cultured in triple N medium, which is Novi, McNeil and Nicoli medium. Thank you. The next parasite will be explained by Muthulakshmi.
Thank you, Priyadashni. I am Muthulakshmi. Now I am going to explain about the parasitology model, Leishmania donovani, their pathogenesis, clinical features and their lab diagnosis. Leishmania donovani causes Kala Azar. The parasite exists in two forms, namely A mastigote and Pro mastigote. The A mastigotes are also called as LD bodies. The A mastigotes are seen in vertebrates and Pro mastigotes are seen in vectors. They have complex life cycle and their definite host is humans and intermediate host is sandfly. Their pathogenesis include the bite of the infected sandfly deposit the Pro mastigote in the wounds. Then they are converted into A mastigotes. The disease depends on host cellular immunity. Their cure correlates with the Th1 response. The clinical manifestations are diarrhea, nocturnal fever, hyperpigmentation of the skin, anemia, cirrhosis, glomerulonephritis. Because of hyperpigmentation, it is also called as the black disease. Their lab diagnosis includes routine hematological investigation. Thank you. The next model will be explained by Apurva.
Thank you, Muthulakshmi. I am Apurva, going to explain about life cycle of Plasmodium falciparum, which mainly causes malaria, with its organism characteristics, clinical features, pathogenesis and lab diagnosis. Plasmodium has four main species like Plasmodium falciparum, Plasmodium ovale, Plasmodium vivax and Plasmodium malariae, where the definitive host are mosquitoes and intermediate host are humans, which mainly spread by female Anopheles mosquito. There are two main stages. Pre-erythrocytic stage occurs in liver, has sporozoites and merozoites, and erythrocytic stage occurs in the blood, which has four forms: sporozoites, schizoids, merozoites and gametocytes. In case of mosquitoes, male gametes, female gametes, ookinete, oocyst and sporozoites. In case of pathogenesis, it causes two main characteristic features: black water fever and three stages of fever: chill, heat and sweat stage of fever. In case of clinical features, it causes fever, malaise, myalgia, nausea, vomiting and indigestion. And in severe cases, it causes anemia, black water fever, hypotension and hypoglycemia. In case of lab diagnosis, acridine orange, which stains the DNA, which is helpful in the identification of the malarial parasites by quantitative Buffy. Thank you. Next model will be continued by Shakti Subramani.
Thank you, Apurva. I am Shakti Subramani. I am going to explain about the parasite model Toxoplasma gondii. This is the life cycle and this is the organism characteristics, clinical features, pathogenesis and lab diagnosis. It is the complex life cycle, so definite hosts are cats and intermediate hosts are rats, humans, etc. The infective form of the Toxoplasma gondii is oocyst. The oocyst can infect the cats. After infection, oocyst enters into the intestine. It liberates the sporozoites. The sporozoites will penetrate the intestinal mucosa and it convert into endozoites. Endozoites undergo gametogamy to form the male and female gametes. It fertilizes to form the zygote. The zygote is converted to oocyst. Clinical features. The most common clinical feature is cervical lymphadenopathy. Headache, malaise, fever may also be occurs. Lab diagnosis. Indirect fluorescence antibody test, indirect chemoagglutination test, ELISA test to detect the antibodies against the Toxoplasma gondii. Thank you. The next cycle will be continued by Tika.
Thank you, Shakti Subramani. I am Kavya and I am here to explain about the life cycle of Tinea solium, its organism characteristics, clinical manifestation and laboratory diagnosis. Teniasis is a type of infection which is caused by Tinea group of parasites. It occurs with contaminated pigs or pork. It usually occurs when human feces reaches the pigs or beef which is eaten raw or undercooked by humans. Teniasis is caused by Tinea saginata, Tinea asiatica and Tinea solium. Tinea solium is present in contaminated pork. It has a complex life cycle in which humans are the definitive host and pigs are the intermediate host. It has two life forms, adult form which is present in the intestines of humans and larva form or cysticerous cellulose. It is present in the tissues of pigs and it is the infective form of humans. The clinical manifestations are abdominal discomfort, bowel disturbances and neurosticeriosis which causes epilepsy and partial seizures. The laboratory diagnosis are stool examination and perianal swab method or NIH swab method.
And the next life cycle is explained by Swati.
Thank you, Kavya. I'm Shwati, going to explain few words about the life cycle of Echinococcus granulosus. Its characteristic features, clinical features, and lab diagnosis. Echinococcus granulosus is of two forms and it causes infections in cattle raising areas and commonly temperate regions. Echinococcus granulosus is of two forms, adult and larval. Adult form is about 3 to 6 millimeter in length and has lifespan of about 5 to 20 months. Larval form is known as hydatid cyst. Hydatid cyst develop in intermediate host and has a commonest site is liver. Hydatid cyst is filled with fluid that has double layered covering, outer ectocyst, inner endocyst. The life cycle of Echinococcus granulosus is complex life cycle, where definitive host is dog, intermediate host is sheep, and the accidental host is humans. The mode of spread is through fecal-oral route. Clinical features are hydatid cyst diseases. In liver, it manifests with abdominal pain and palpable swelling. In lungs, it manifests with cough, chest pain, and hemoptysis. In bone, it leads to bone erosions. Lab diagnoses are routine X-ray and ultrasound studies. And along with that, serological tests are also made. The main line of treatment is surgery, and sufficient care is essential to prevent the leakage of hydatid fluid while doing surgery. And the proper personal hygiene is essential, and thorough washing of hands after handling pets is necessary for prevention of such diseases. Thank you, and the next life cycle will be continued by Preeti.
Thank you, Swati. I am Preeti. I am going to explain the life cycle of Homoeopathy. This is life cycle along with its organism characteristics, pathogenesis, clinical features, and lab diagnosis. Homoeopathy, which causes the illness schistosomiasis. They exist in 5 forms: adult, sporocyst, cercaria, cystomesis. They have 2 suckers, oral and the ventral suckers. Within the ventral suckers, it forms the gynecophobic canal. Humans are infected by the cercaria while swimming and bathing in the contaminated water. Cercaria can penetrate through the skin and it enters the bloodstream to reach the liver. But water when takes reaches the urinary bladder to pass in the urine, particularly during afternoons. This life cycle is a complex life cycle. Humans are the definite host and snails are the intermediate host. Clinical features: it causes the cercaria dermatitis, swimmer's itch, symptoms like fever, cough, lymphadenopathy, and urticaria. This condition is called catayama fever, along with the pseudium hematuria noted. Lab diagnosis: urine is collected. Tests like cercaria reaction will be done to detect the antibodies against the cercaria antigens. Now I call upon Shanmati to explain this life cycle. Thank you.
Thank you, Preeti. I am Shanmati. I am going to explain about the life cycle of Bacillopsis busci, its organism characteristics, pathogenesis, and clinical features. First, it is the largest trematode infecting human. It is also called as giant intestinal fruits. In India, it occurs in Assam and West Bengal. Organism characteristics: it occurs in 6 forms, that is adult, Meracidium, Sporocyst, Rhedia, Cercaria, and Metacercaria. The adult live in the small intestine of the human. The mature adults that lays egg that passes in the feces. Life cycle: it is a complex life cycle. The definite host is a human and intermediate host is a snake. The infective form of a human is a Meracidium. Clinical features and pathogenesis: it causes Bacillopsiasis. The worm can produce localized inflammation and ulceration at the site of attachments. It also causes ascites, anasarca, and intestinal obstructions. Heavy injections leads to fever, abdominal pain, and diarrhea. Next, it is a lab diagnosis. It is a stool examinations. It is achieved by demonstration of a operculated egg in the feces. Thank you. The next cycle will be continued by Haripriya and Padmapriya.
Thank you, Shanmati. Hi, I am Haripriya. I am Padmapriya. We are going to explain about the life cycle of the Ascaris lumbricoids, which has pathogenicity, clinical features, and lab diagnosis. Ascaris lumbricoids are the largest intestinal nematodes which we can see in human beings. They are particularly prevalent in areas where there are inadequate sanitation and where untreated human feces are used as night soil. The characteristics of the organisms are they exist in 2 forms, adult and larva. The adult form are the largest intestinal nematodes which we can see in human. They are generally cylindrical, pinkish in color, measures up to 40 cm in length and have a tapering ends. Adult male measures from 20 to 40 cm in length and 2 to 4 mm in diameter, whereas adult female measures from 15 to 30 cm in length and 3 to 6 mm in diameter. Adult female are oviparous, so the fertilized eggs measures from 60 mm in length into 40 mm in length, whereas unfertilized eggs measures from 90 mm in length into 45 mm in length. There will be no gap between the eggshell and the contents.
Pathogenicity and clinical features. Ascaris lumbricoides causes ascariasis. The clinical manifestation of Ascaris lumbricoides has two forms, both adult and larva forms. The migrating larva produces signs and symptoms mainly on the lungs. The patient develops non-protective discomfort and dyspnea. Occasionally, blood-tinged sputum may be expectorated. The penetrating larva produces microhemorrhage and eosinophilic response to the host. Lab diagnosis. Intestinal ascariasis is diagnosed by the demonstration of the fecal matter. In eosinophilic pneumonia, plain X-rays, basophilic studies and ultrasound may be demonstrated in the intestinal walls. Thank you. And now I call upon my friend Monica to explain further life cycle.
Thank you, Haripya. I am Monica. I am here to explain about the life cycle of Troizean trichula, its organism characteristics, clinical features and lab diagnosis. It is the commonest nematode. It has simple life cycle, only one host which is a human. It occurs in two forms, adult form and larval form. Adult form lives in cecum and appendix of the human beings. Its anterior 3/5 is thin, elongated and coiled. It has whitish pinky color and it is wave-like in position. Then larval form. Larval form exists in adult male and adult female. Adult male is 30 to 40 mm long and adult female is 40 to 50 mm long. Adult male posterior end is elongated and coiled. It has single sheath spicule. In adult female, its posterior end is round and blunted. Then it causes trichuriasis. It has light infection and heavier infection. Light infections are asymptomatic and heavier infection has abdominal pain and blood and mucus diarrhea. Humans are infected by embryonic larva which has fully developed larva. Then humans acquire infection by ingesting the egg along with food and water. Then lab diagnosis. In stool examination, the characteristics of barrel-shaped eggs are seen in the figures. Then the left cycle will be continued by the Kausalya.
Thank you, Monica. I am Kausalan. I am going to explain about the Wuchereria band grafting. Life cycle of the Wuchereria band grafting. Pathogenicity, clinical features, lab diagnosis. It is most widely distributed human filaria parasite found in India, China, South America, most portion of the Africa. Organic characteristics. It exists three forms: adult form, microfilaria, larva. Adult form live in lymphatic tissues. Microfilaria live in blood vessels. It is complex life cycle. Definite host is human. Intermediate host is mosquito. Infective form is microfilaria. Pathogenesis and clinical features. It causes Wucheriasis. Adult form causes dilatation and thickening of the lymphatic vessels and the lymph nodes. Mechanical obstruction and mechanical irritation and toxin released by adult form lead to inflammation of the lymphatic vessels and lymph